Welcome back, everybody. In today's lecture, we're going to be continuing our journey down the path of exploring a multitude of different types of mental health disorders that are described in what again we call the DSM, or the Diagnostic and Statistical Manual of Mental Disorders. We are going to continue on our discussion on mood disorders first in today's class, and then afterward we're going to be examining a very multifaceted, extremely controversial and problematic disorder in schizophrenia. I'll provide more context on that when we get to it, but before we get to that specific section, I do want to turn our attention back to mood disorders, the topic we discussed in our previous lecture. For those of you that need a little bit of a review to find where we were at, if you recall back to our last lecture, we spent some time talking about one particular type of mood disorder, what's called depression. Depression can actually exist in a variety of different forms and at a variety of different levels, but when looking at depression, it's important to note that it's just one type of mood disorder that's out there. In this lecture, we're going to be looking at other mood disorders, issues with basic emotions, in particular affect, and kind of how they also fit under the umbrella but are unique from depression, that most commonly cited and discussed mood disorder that's out there. We're going to start when looking at these mood disorders with one that on the surface, if we're looking just at behavioral and kind of emotional patterns, almost seems exactly like depression. It's one called seasonal affective disorder. So what is seasonal affective disorder? Well, if we're looking at the manifestation of symptoms when people are in their kind of worst stages of seasonal affective disorder, we see is something that looks almost identical to depression. There's a wide range of symptoms that pop up that are both cognitive, affective, and behavioral. And honestly, if you saw somebody struggling with the final throes of seasonal affective disorder, you would be very challenged to be able to separate out what they're experiencing from somebody who's struggling with depression. What makes this different is that seasonal affective disorder is a very kind of predictable pattern of change that many individuals go through on a year-by-year basis. It's very highly correlated with the changes of seasons, and in particular, the transition from summer into winter. What we tend to see with individuals struggling with seasonal affective disorder is that during the winter months, this is obviously November, December, January, February for people in the northern hemisphere, and well, the opposite for people in the southern hemisphere. There's this increased level of depressive symptoms that tends to actually, the worst, kind of again rival what we see with depression. Now, this cyclical pattern is not common in depression, and it's one of the things that makes seasonal affective disorder distinct. What also is really important when we talked about seasonal affective disorder is that the source of it seems to be coming from a different place. What we see, first off, is that this is a particular disorder that's very region specific. So the closer you move to the poles, both the northern and southern poles, what you tend to see is that the prevalence of this disorder becomes more and more common, and the magnitude of the symptoms become more and more robust. And this is telling us again that even though it might look like depression on the surface, this pattern and depending upon where you're at, the kind of location specificity suggests that we're actually looking at a different disorder. If we needed one more conclusive piece of evidence that this was something that was unique, it's in a very common treatment that's proven to be very effective for this disorder, something called light therapy, where individuals are exposed to UV light, the thing that we often link to the kind of triggering of this disorder. And what we've seen is that extensive light therapy, especially if people are exposed for an extremely long period of time on a regular basis, can help ameliorate a lot of the symptoms that people are struggling with seasonal affective disorder. So again, even though on the surface it seems to look like depression, This unique cyclical pattern, the fact that it does seem to be very region specific, that's based on how much light somebody's exposed to, and the fact that light therapy works, strongly suggests that we're looking at something that's different, even if the end results are pretty darn similar. And for those of you wondering, those struggling with day-to-day depression have not shown much in terms of responsiveness to light therapy. Again, highlighting how that is distinct from seasonal affective disorder. And this is also true for another disorder that on the surface sort of just looks like mild depression, something called persistent depressive disorder. It traditionally has been called dysthymia, but in the newest edition of the DSM, this was renamed persistent depressive disorder to give kind of an indicator of what it is that we're looking at. As the name does imply, persistent depressive disorder is sort of similar to depression, but it's much, much longer lasting than depression. And what we see is that to even be diagnosed with it, you need to display symptoms for at least 2 years as an adult and 1 year as a child, something that's not very common for individuals struggling with depression, to have symptoms that persist for that long without any remission whatsoever. And it's even more uncommon for it to last much longer than that, which is typically common for people struggling with persistent depressive disorder. I guess one silver lining for this particular disorder is people who are struggling with it tend to report less severe depressive symptoms. And that's both good and sort of bad if we think about it. It's not necessarily that common, only found about 2% of the population, but those that struggle with it tend to find themselves at a place where it's tough to really detect that they have these issues. It's really tough to overcome them, because when they describe their kind of mild symptoms and mild cognitions and emotional responses to things, there's this underlying assumption that a lot of these issues are sort of in their heads, and it's more of a personality thing than a mental health issue. And that can lead to a lot of individuals struggling with these issues to have these persistent problems for years, sometimes decades, without seeking therapy or without even realizing that this is something that should be looked at and should involve some type of treatments to kind of help people kind of get their thought patterns and the reactions to things at a place where they can be happier and more productive in their lives. It's really important to note here that that linking of this to about 2.5% of the population is a debated topic. There are some individuals that suggest that this might be a much more common thing than we think. It might be that some individuals diagnosed with depression would be better off being described as having persistent depressive disorder. There's also some that argue that maybe this just isn't nearly diagnosed enough. But regardless, these numbers and information on this all suggest that we are looking at something that has a lot of the symptoms of depression, but it's unique because of how long it lasts and because of how it kind of manifests itself in specific disorders, or sorry, specific symptoms. The last disorder that we're going to be talking about in these mood disorders category is a very unique one. It's called bipolar disorder, or sometimes you'll hear it referenced as manic depressive disorder. And this one is a mood disorder, but usually the thing that kind of makes it interesting and unusual is the fact that this one has not only the negative moods typically linked to it, depression or things that are closely linked to depression, but also something that we call mania or manic symptoms. These manic symptoms can manifest themselves just like depression in a lot of different ways. Some individuals who express manic symptoms are very active, very uninhibited. Others get very upset and agitated. Some kind of go to a weird spiritual mental world, while others just kind of get themselves overly active and can't slow themselves down. In essence, just like depression, mania can manifest itself in different ways, and just like depression, it can also vary in terms of severity. So what many clinicians do when looking at bipolar disorder is they try to not only identify somebody who's struggling with this mental health issue, but categorize where they're at in terms of the magnitude of their issues to be able to communicate with clients and other therapists what a person's actually going through. So even though we don't always fit perfectly into specific categories, one of the terms that you'll hear when you hear about bipolar disorder is whether or not somebody is type 1, type 2, or cyclothymic. For somebody to be described as type 1, they need to have gone through at least one full-blown manic episode. Usually when somebody gets qualified as this, they've gone through several manic episodes throughout a portion of their lives and are seeking treatment for that. Some individuals with bipolar type 1 disorder also have severe depression or mild depression, or actually just fluctuate between traditionally kind of stable conditions and what were considered manic conditions. It does vary from person to person within this type 1 category, but if you have a full-blown manic episode, you'll probably be defined as having what we again call bipolar type 1 disorder. Bipolar type 2 disorder involves kind of lessened but more agitated manic stages that we call hypomania. For somebody to qualify as bipolar type 2, they not only do need to display these hypomanic symptoms, but they also need to display severe depression in phases as they're kind of cycling throughout these different symptoms. If somebody does not get to that severe depression level, they are not defined as bipolar type 2, but instead defined as what we call cyclothymic, where they have some type of hypomania and then milder symptoms of depression that they're fluctuating between. And these fluctuations can last anywhere from a day or two to an extended period of time for weeks or months even. Now, this is not a very common disorder, fortunately. It's only found in about 1% of the population, and this one is very highly heritable. There's numerous studies that have suggested that this is something that seems to be genetic in nature, even if there are certain things in the environment that can increase the proclivity for somebody developing these symptoms at some point in their life. So what many clinicians look for is trying to figure out not only if somebody has genetic link to these things when symptoms start to emerge, but what category somebody can be put in based on the manifestations of their symptoms. And this does have a big impact on the types of drug interventions that are used for individuals struggling with this. Unfortunately, drug interventions are kind of the more common thing used for this particular disorder because it is a lifelong thing. So what often happens is there's some type of therapy used in conjunction with these drug interventions to try to help individuals deal with both the extremes that they often are going through when struggling with this specific mood disorder that is, again, very unique because of the manic component to it. But just to reiterate, when looking at those three disorders that we've discussed so far, even though they're all very unique, all different in terms of their prevalence and the symptoms that we focus on, they're just like anxiety disorders, all kind of under the same umbrella of disorders together. In this case, they're under the umbrella of mood disorders. And when clinicians try to help individuals, what they do is not only look at the specific disorder, but they try to differentiate between what type of mood disorder somebody has, and that can have an impact on the plans for treatment and the attempts to understand the potential sources of the problems that these individuals are struggling with. And this is also true for the next broad classification of disorders that we're going to be looking at next. And that classification of disorders that we're going to be looking at next is called schizophrenia. Now, schizophrenia is a very, just like depression and some of the anxiety disorders that we've talked about, multifaceted thing that we are going to break down as we progress. But before we do that, one of the things that we first have to do when discussing schizophrenia is describe what it's not. Because unfortunately, in the media and in lots of different sources, schizophrenia is often misrepresented. If any of you ever have watched a horror film or some sensationalized movie that tries to depict somebody with schizophrenia, you'll often see that they tend to get the descriptions of these individuals and symptoms that they're manifesting wrong. Oftentimes, schizophrenia, the kind of break from reality is paired with individuals being multiple people or taking pleasure in the suffering of others, something we call sociopathic disorder, or just not being able to connect to anybody in the world around them, something called antisocial personality disorder. There might be occasionally some overlap between schizophrenia and some of these things, but it's certainly not common. Usually schizophrenia is a disorder on its own that doesn't have to relate to any other thing in particular. And when we're looking at schizophrenia, just the basic definition of it, we're looking at is a mental health issue that involves an individual's disconnect in a multitude of different ways from reality that's both cognitive and emotional in nature. And this disconnect can be mild or really extreme. And it often, if untreated, grows as a person kind of gets deeper and deeper into their symptoms of schizophrenia that unfortunately, as we're going to talk about later, persist through life. And just to kind of understand what it is we're looking at, I decided to include a picture by an artist that tried to depict his cat in several images as he was progressing in symptoms of schizophrenia and trying to give people a sense of what he saw when he looked at his pet. The upper left-hand corner image is an image of what he originally saw when he started to experience symptoms. The upper right-hand corner is the next evolution, and so on until you get to the lower right-hand corner, which is what, again, he swore was something he encountered when looking at his cat. Now, this is not necessarily typical of all individuals struggling with schizophrenia, but what you can see in this is kind of the slow, gradual break from reality that unfortunately many people struggling with schizophrenia encounter unless they can seek out help and try to have some type of intervention to help them kind of coordinate with the world around them and as they try to correct, but try to corral some of the cognitive and emotional symptoms that pop up with this disorder. Now, when talking about schizophrenia, we can break it up in a number of different ways. As I mentioned, it's a very multifaceted disorder that manifests itself in different ways for different individuals. One of the ways that many clinicians break up schizophrenia is based on the symptoms that people are displaying. And when we talk about the symptoms that people are displaying, we can sort of clump them into four distinct categories: what we call positive symptoms, negative symptoms, cognitive symptoms, and affective symptoms. Now, I know the name positive symptoms seems to suggest that we're looking at things that these people have sort of going for them or things that they can utilize, but that's certainly not what positive symptoms mean when looking at it from a definitional standpoint in schizophrenia. Positive symptoms for schizophrenia are typically behaviors and thoughts that these individuals are displaying that are not a part of a typical person's repertoire. Negative symptoms, if we're looking at the opposite of positive symptoms, are the behaviors and thoughts that these individuals are not displaying or at least diminished that is a part of a typical person's repertoire. Cognitive symptoms are the kind of atypical thought patterns that are popping up in these individuals' minds. Usually this relates to specific cognitive components, so things like attention, organization, not necessarily the inner dialogue that somebody's having, but just how these cognitive components can be kind of atypical or skewed. And then affective symptoms, again, are like cognitive symptoms in that we're not looking at necessarily how kind of affect is changed per se, but kind of how these individuals react to things emotionally in an atypical way and whether or not specific trends in affect pop up. And we're going to break down all four of these different categories of symptoms in this lecture because I feel like understanding these things and help you better understand some of the different schizophrenia types that are discussed in the book and just understand the kind of complexity of schizophrenia as a whole. And we're going to start with the positive symptoms. So what are the positive symptoms of schizophrenia? Again, just to reiterate, we're not looking at things that these individuals necessarily have going for them. These are the thoughts and the kind of atypical behaviors that these people are displaying that are not a part of a typical individual's repertoire. The most common positive symptom that's referenced are these things called hallucinations, when people perceive things through some type of sensory system that's not actually there. Now, technically, hallucinations can exist for all of our different sensory systems, but the most common ones are auditory and visual hallucinations that people experience, with auditory ones being a little bit more common. Auditory hallucinations can exist in a variety of different forms, with sometimes individuals hearing specific voices or sounds or kind of a combination of these things. And they can vary not only in the frequency that these individuals are experiencing them, but also the complexity of them. How kind of specific they are or wide-ranging they are across a wide number of situations. Not only are these things kind of challenging to pin down in terms of what somebody's going to experience, but new research on hallucinations has shed a light on why these things are so difficult for these individuals to kind of, identify when they start to experience them. Numerous studies have shown that individuals who report hearing voices or seeing things that aren't there are actually showing brain activity in regions linked to auditory processing and visual processing, even when there is no presence of specific stimuli in the environment. And this activity in the brain really highlights how challenging things can be for these individuals experiencing these hallucinations, because you're essentially needing to learn how to not trust your mind, not trust your brain, and the messages that it's conveying to other portions of the brain. These hallucinations are also paired oftentimes with another type of positive symptom called delusions, where people start to display very rigid and unfounded false beliefs about certain aspects of their environment around them. There's a wide range of different types of delusions that people experience, but three in particular are more common than some of the other ones. One that pops up a lot is something called a delusion of persecution, where there's this belief that somehow there's a group of individuals, or maybe even a specific person, that's doing something to persecute the person. Now, this could be trying to harm the individual. It could be trying to spy on the individual. It could be trying to just ruin the reputation of a person. But whatever it is, these delusions of persecution tend to be very rigid once they start to get formed in an individual's mind. And even with contradictory evidence, are very tough to overcome once these persons form them. This is also true for another type of delusion that pops up often, called a grandiose delusion. This belief in some either unusual importance or maybe in occasion some type of almost superpower or superhuman ability to do something or achieve something that isn't common for most people. These two can sometimes be paired with another common delusion called a delusion of reference, where individuals start to see connections between things or tie stuff together in ways that don't make much logical sense. You might have seen in movies or other shows people taking newspaper headlines and finding ways to combine the letters within them to get some abstract meaning or reference from them. And sometimes it almost looks like they are finding a way to derive some very interesting message from this stuff. But what we have to understand is that these delusions are not really based on reality. And even if the end product makes some logical sense, the path to get there is often very chaotic and unreliable, and it creates these problems for these individuals where they struggle to, again, distinguish between reality and what it is their minds are screaming at them is actually going on. And with all these delusions and other ones, just like the hallucinations, for clinicians who encounter people who are struggling with these things, it's very tough to try to get them to overcome their issues, because unfortunately, once these things are rigidly formed, they stick in the mind and the brain, and it's very challenging unless you can find some type of intervention, sometimes medical in nature, that can help subside some of these thought patterns that start to emerge. This is also true when it comes to the negative symptoms of schizophrenia that people can experience. As a reminder, negative symptoms are not just the bad things that these people are struggling with, but they're the symptoms where people are kind of lacking displays of things that are a part of a normal person's, typical person's repertoire, I guess we should say. The most common negative symptom out there is something called anhedonia, which is actually a symptom that can pop up in other disorders as well. Anhedonia is the diminished ability to experience the wide range of emotions that most individuals experience. And it's in particular more focused, if we're looking at schizophrenia, on the inability to experience positive emotions. And this kind of lacking ability to go through a wide range of emotions can impact not only a person's cognitive functioning, but also can impact a large number of their social behaviors as well, which can on their own be described as negative symptoms of schizophrenia. When people experience anhedonia, another thing that often is manifested in them is something called blunted affect, where they're not only getting kind of a limited range of emotions experienced internally, but they're displaying a limited range of emotions in their face and their demeanor and even their language communication. Blunted affect typically focuses just on how we express our emotions on our face, but it also is a component in language and how we tend to accentuate certain things by saying certain words louder or slowing down on certain components. And another big aspect of blunted affect is kind of the inability to make consistent eye contact as a result of some of the other cognitive symptoms going on in the head. Now, these two negative symptoms on their own can be problematic, but what also tends to happen because of some of the positive symptoms that are common with schizophrenia is individuals struggling with schizophrenia also display the negative symptoms of social withdrawal and poor self-care. Primarily because of the kind of irregular thought patterns and other things that make taking care of ourselves and engaging in social interactions extremely challenging. And these negative symptoms on their own can obviously be problematic, but when combined with the positive symptoms and also some of the other ones, what we can see is how detrimental a lot of these symptoms can be on an individual's ability to function on a day-to-day basis. Again, what are the other categories of symptoms that are out there? Well, the other two categories that are kind of a part of schizophrenia nowadays are what we call cognitive symptoms and affective symptoms. Cognitive symptoms are ones that are oftentimes highlighted in shows and in clinical work, where you see individuals not only having those unfounded thoughts and kind of the lack of specific emotional skills, but you also see these individuals in conversation and just in their cognitive functioning display sort of a lacking ability of doing things that many of us take for granted. When we have conversations, we have the ability to stick on a specific topic and not jump wildly from section to section or idea to idea. And when we have a statement that we want to make, we tend to get to the end of that statement without being interrupted. For many individuals struggling with schizophrenia, this is not the case. They tend to have conversations where words come together in sentences that don't make much sense, and oftentimes if we're trying to find a coherent theme behind those words, we have to recognize and pick up on the jumps that a person is going through, maybe even mid-sentence, from topic to topic. Now, I know many of you, when you hear these descriptions, might be thinking of your teenage friends or political figures or other individuals who really struggle to form coherent sentences or make much sense. That's not quite what we're looking at here with cognitive symptoms. We're looking at individuals who really do struggle with basic memory function, basic thought abilities, and the ability to kind of convey themselves in any coherent way whatsoever while engaged in conversation. In my typical in-person class, to highlight how this might manifest itself, I do put up a video where students can watch a woman struggling with schizophrenia symptoms, and they can see her not only talking about some of the hallucinations and delusions that she's experiencing, but also see kind of the manifestation of these cognitive symptoms in a conversation she has with a clinician. Many students are often enticed by the fact that they can parse out some meaning from what she's saying and try to decode some of the other things that she's mentioning that seems to be tough to follow. And they often argue that, maybe her brain is just working in a slightly different way, but there is some logic to what she's saying. I want us to note here in this video that that statement that many students have made is true. Many people struggling with symptoms of schizophrenia are trying to make points, trying to convey something in a logical way, but it often, unfortunately, comes across as a garbled mess that requires a lot of effort and work to parse out into something that's meaningful. And this is what happens when these cognitive symptoms of schizophrenia appear. It's not that it's just a disjointed, garbled mess that has no rhyme or reason to it. It's just a very challenging, disjointed, garbled mess that takes considerable amount of effort to really derive much from it. And this is also true when we look at some of the affective symptoms that people experience. Oftentimes, people struggling with schizophrenia display depression and anxiety as a result of their symptoms, which is a logical thing. But the severity of the symptoms, when they pop up, the kind of things that trigger some of these affect symptoms is erratic. And the kind of atypical pattern of these things is what, again, makes these symptoms distinct and diagnosable in schizophrenia, not just something that happens as a result of other symptoms that people are struggling with from schizophrenia. And now that we've covered all of these different symptoms, I guess as you've recognized, that schizophrenia can manifest itself in a lot of different ways, which is why many clinicians, when talking about schizophrenia, like to not only have those different types of symptoms discussed, but also like to put people in specific categories based on the types of symptoms that they're manifesting. The book does talk about some of the different types of schizophrenia that are out there. It doesn't necessarily encapsulate all the different things that people with schizophrenia might experience, but just having these symptoms covered should give you a better ability to kind of process these issues with schizophrenia that are listed in the book. Another thing that's important to note is that when clinicians are looking to diagnose somebody and put them in a specific category, they tend to look for not just these specific symptoms, but very specific components that kind of qualify somebody as being diagnosed with schizophrenia. You not only need to display at least two of the symptoms that we've talked about, but have some indicator that daily functioning life has become significantly more challenging recently as a result of the emergence of these symptoms. There's ways to kind of hedge if somebody is experiencing really robust hallucinations or delusions that maybe they're not necessarily causing chaos in a person's life, but that they're definitely worth treating. So it's not that you have to meet these thresholds or there's no way somebody would see somebody with some of these symptoms of schizophrenia, but typically the DSM, just to kind of qualify people into specific groups, does have certain thresholds that they're looking for. And another thing that they're very insistent on is you have to be sure that these people coming in are not experiencing these symptoms because of some other component, like drug-induced experiences or other aspects of kind of their brain having some type of damage going on. With all of that in mind, about 1 to 2% of the population, depending upon the samples that we're looking at, are diagnosed with this at some point in their life. And men in this particular case were diagnosed just a little bit more than women. It's not quite a 2 to 1 ratio. It's a 7 to 5 ratio is what we found in most studies. But it's a noticeable difference that has led people to look for specific genetic components linked to our last chromosome that could potentially be precursors to the development of schizophrenia, something we'll talk about a little bit later. What we also see with schizophrenia, which is interesting to note, is that this one takes a long time to manifest itself. Usually people don't display any symptoms of schizophrenia until their late teenage years, and sometimes even into our mid-20s do we see the first emergence of symptoms in some people. And this can be kind of troubling for clinicians in their attempts to try to understand the source of symptoms of schizophrenia and to be able to tease it apart from things that have often been in our minds intertwined with it. Many individuals historically have linked the emergence of schizophrenia to things like drug use or traumatic experiences when we're children. And being able to tie those single events or these kind of series of events with something that pops up or at least is diagnosed much later in life is very challenging for clinicians. But it's one of the many things that are being tackled by clinical psychologists and experimental psychologists trying to better understand schizophrenia. And this is something that has actually spurned on other research and ideas about what could potentially be linked to the emergence of this disorder when it pops up in individuals much later in their life than many disorders that we've talked about thus far. It is important to note that heritability research has been very robust in suggesting that even if we can't necessarily find a specific gene that's the precursor to developing schizophrenia, numerous twin studies have shown that this is a very heritable thing. Usually, if an identical twin develops symptoms of schizophrenia, their twin has a 50-50 chance of developing symptoms at some point in their life. This is also true of the children of parents who've both been diagnosed with schizophrenia. And as you move down the lineage and the genetic overlap, we see a very predictable change in heritability rates and people related to these individuals being diagnosed with schizophrenia. All of it screams that there is a genetic component there, but it also screams that it's not just genes. And if it was entirely genes, one would assume that an identical twin would have a 100% chance of developing symptoms of schizophrenia if their twin had developed it. The offspring of two parents who had symptoms of schizophrenia would almost have a guaranteed chance of developing schizophrenia themselves. But we don't see this, which has led to researchers looking for other avenues, and many of these have focused on how this starts to grow and manifest itself in our late adolescence, early adulthood years. Numerous studies have shown that by the time symptoms of schizophrenia have become what we might call full-blown, we see quantifiable differences in the cellular and structural areas of the brain for individuals struggling with schizophrenia and controls. There's a large difference in the hippocampus, areas of the cerebral cortex, and the flow of cells within these regions that cause individuals with schizophrenia to kind of have brains that sort of look like chaotic, tangled messes at both the cellular and structural level. And what causes these decays is something that's hotly debated. And what makes this even more problematic and tough to differentiate is that when people start experiencing early symptoms of schizophrenia, we can't see any indications of this often in the brain at both the structural and cellular level. It's not until the symptoms start to get more and more pronounced that the brain starts to change and alter. And this has led many researchers to ask, is this shift in the brain a causal thing where the symptoms are becoming more prominent as the brain continues to shift? Or is it a correlational thing? Is it the brain shifting as the mind shifts and the neurons in the brain don't communicate in an effective way? Is the brain sort of adapting in an atypical, maladaptive way to the things that we're encountering? And this has led to researchers looking for other things that might put the brain down a path to this, even if we can't predict it in the early childhood years. One topic that was talked about extensively a few decades ago was this idea of something called the neurodevelopmental hypothesis. How maybe people born with a genetic predisposition for this might only display symptoms if they encounter certain things during the second and third trimester while in gestation in their mother's womb that causes these things to eventually emerge in adulthood. They tried to trace this thing to the influenza virus, lots of maternal stress, diet, the things that the mother was exposed to in terms of the water, the electrical fields around them. It was something that was pushed on a lot of different areas to try to understand some of the things that were the sources of it. But what we found is small correlations between a lot of different things in the development of schizophrenia, but no thing in particular that seemed to be the main catalyst behind the development of symptoms of schizophrenia. And what it's led to is an unclear picture that has pushed many people to look for other sources of the emergence of schizophrenia in adulthood. One of the models that we use a lot today is one we talked about previously called the diathesis stress model, that focuses a lot on the biological components that are probably critical players in the development of schizophrenia, but also the social components, the stresses that a person's experiences, the choices that they're making, the things that are happening to them that could either alleviate or exacerbate the proclivity of developing symptoms of schizophrenia in people. And this leads us to another really important topic, and that's once people start to display symptoms, how do we help them? How do we ameliorate the problems, and how do we maybe prevent them from going into the extreme decline that sometimes happens, or oftentimes happens, with many people struggling with schizophrenia? If we look for a clinical fix, this cognitive behavioral therapy has proven to be somewhat effective, at least on the symptom level. For people who develop milder, we would say, symptoms of schizophrenia in terms of their hallucinations or delusions, or even their negative symptoms of flat affect and anhedonia, cognitive behavioral therapy has proven to be somewhat effective in helping people kind of just correct course on these things and not be impacted by them as much as just some placebo or not getting treatment at all. But historically, if we're looking for treatments for individuals struggling with schizophrenia, cognitive behavioral therapy or other types of psychotherapy aren't really sufficient. And instead, the thing that's often done for people who start to display symptoms is they're given some type of medication. Antipsychotic, or sometimes what we call neuroleptic drugs, are the most commonly prescribed drugs. And these all come in a lot of different forms, and they're all designed to help relieve symptoms for individuals. The frustrating thing with these medications is they all work really well right off the bat, activating different parts of the brain, turning off certain parts of the brain that are using things like glutamate, dopamine, but they come oftentimes with them over time with unpleasant side effects, at least the ones in the past, produce some really horrible side effects like tardive dyskinesia, dystonia, seizures, a lot of other things that you can read about in the book. And those side effects can be enough to scare people away from these drugs in the first place. But there's other issues with them as well. And that's the fact that many drugs, even though they work instantly, tend to see a waning in their effectiveness over time. Almost all antipsychotic drugs that a person struggling with schizophrenia takes work right away. But after a few months, usually those drugs wane in their effectiveness to where after about a year, only about 50% of people taking an antipsychotic drug, even if it's at the right level, see a kind of remission of their symptoms still. And what really exacerbates this issue is that the tolerance for a lot of these drugs tends to increase for people over time, which means you often have to not only find the right drugs, but find the right level of these drugs to help people deal with the wide range of symptoms that they're struggling with. This leads to a conversation that happens a lot in the clinical field when it comes to treating schizophrenia, and it's this push to find what's called the right drug for a person. This means both the right combination of antipsychotics and the right magnitude of those things that are constantly being tweaked over time as people's symptoms change. This also is something that's probably important to note, happens a lot with bipolar disorder, another one that we talked about earlier. But if somebody is seeking therapy and taking drugs, one nice thing to note with this is that these things can work. One of the big challenges once you find one that works is just trying to find a way to kind of keep a person on those drugs when the symptoms are abated, which can be, oddly enough, a pretty big challenge. Because it's one thing to take a drug and have the voices go away and you realize that's great, but if you've been taking a drug for months or years and you've never had voices in that time span, you might start to question whether or not those voices or those things are really going to be there if you go off the drug. And unfortunately, when people wean themselves, sometimes those things return, and there's not this recognition that it's the going off of the drug that caused them to pop up or caused them to return. It is a constant battle, unfortunately, with people struggling with schizophrenia. Not only figuring out the sources of these things, but trying to find the right path to health once these things are diagnosed and once there is a fix that's sort of put in place. And this sort of sad topic is where we're going to actually end this class. But I do want us to note here that, when we're talking about schizophrenia or all the mood disorders out there, that there is a lot of research going into these topics, and there's a lot of positive things that have come out of that research that give clinicians hope. And this is going to be the same thing that we're going to see in the substance abuse lecture that some of you will be seeing soon. So make sure that you get through that, and when you get through that, believe it or not, we're sort of hitting the end here. So I'm going to wish all of you the best in your studies. I hope you're all doing well. I'm hoping everybody's raring to go as we near the finish line here. And if you have any questions, feel free to email me. I'll be happy to help. Otherwise, take care all. Best of luck to you, and well, I hope to speak to you soon.